sacrificed to protect our freedom. This year is even more special because it marks the 75th anniversary of the end of World War II, the 70th anniversary of the beginning of the Korean War, and the 30th anniversary of both the end of the Panama invasion and the beginning of Desert Shield. We are proud and fortunate to have hundreds of veterans and active duty servicemen among our attendees today and our team at Ascension. Please join with me in thanking them for their service. During today's conference, please use the Q&A feature to ask questions. We will do our best to answer them at the end of the conference. You must complete your sign-in evaluation within 7 days of the conference. You'll do this by going to www.eeds.com. The evaluation code for this lecture is 85CUDS. That's 85, C as in cat, U as in umbrella, D as in Dana, and S as in Sam. We ask that everyone that's in attendance to please take the evaluation and let us know how we're doing. The planning committee and Dr. Stalin have no relevant financial relationships to disclose. Our first speaker today is Dr. Stalin. He finished his general surgery training at Albert Einstein College of Medicine in New York. He completed his training in bariatric surgery at Cleveland Clinic, and he is practicing bariatric surgery and is presently the director of bariatric surgery at Ascension St. Mary's Hospital. He is the recipient of numerous outstanding teaching and education rewards. Please join with me in welcoming Dr. Stalin.
Click on that to open it in Zoom.
Ready for me, Dana? Yeah, thanks for the kind introduction, and thanks for having me here. So our topic for today is going to be bariatric surgery, specifically with the focus on how it relates to diabetes. Let's see. Okay, so a surgical cure for diabetes, who knew? So is it a myth that only surgeons endorse bariatric surgery? You know what Warren Buffett said, never ask a barber if you need a haircut. You know what the answer is going to be. You know, but you have all these organizations, medical organizations, including CMS Medicare, the American Diabetes Association, the American Medical Association, multiple organizations endorsing bariatric surgery for the management of chronic severe obesity and its associated comorbid conditions. So all this systematically first started out in 1995. There was Walter Porres who presented this seminal paper at the annual meeting of the American Surgical Association. It was a 14-year experience with 600 patients, and he noted that 85% of the patients in a series with type 2 diabetes resolved their diabetes after a Roux-en-Y gastric bypass. So before that, it was merely a observation, you know, relegated to dinner side conversations saying, hey, you know, did you notice my patient just put their diabetes into remission after a gastric bypass? But this was a seminal study that actually proved the thought with the numbers to back it up.
Dr. Stalin, your
Yes.
slides are not currently projecting. Can you share your screen?
I'm pretty sure I'm sharing my screen. Yes, share screen is enabled.
Click share screen and then the window that you want us to see.
I'll see. Okay. Sorry about that. Do you see it now?
Now we do. Go ahead and go into slide presentation mode.
Okay, perfect. Yeah. Okay. So as far as our own experiences or my own experience is concerned, it's more than 1,000 patients over the past almost couple of decades. And, you'll see half of them are Roux-en-Y gastric bypasses, a few lab bands, it's almost extinct now, a handful of duodenal switches, uh, revisional procedures, and of course, the sleeve gastrectomy has really taken over as the primary procedure over the past few years. So the algorithm for a patient to get into bariatric surgery goes something like this. Typically they attend mandatory informational seminar so that they have some sort of a background into what their choices are. They need to know what their options are with regards to diet, exercise, lifestyle changes, medical management, pharmacological management, and bariatric surgery. They attend some group meetings. Psychiatric or psychological evaluation is mandatory because we want to make sure that there aren't any coexisting eating disorders that could torpedo our surgical procedure if we decide to go down that route. You can't take someone with an eating disorder, don't address the eating disorder first, and then expect the surgery to be successful. So having a eating disorder doesn't mean that it excludes your eligibility for surgery. It just means that it needs to be managed before we go ahead with the surgery. So it's not a contraindication by any means. I just wanted to be clear on that. In fact, if you look at the statistics, there are multiple papers that will tell you that there is close to a 90% association of eating disorders in patients with diagnosis of morbid obesity. They all end up seeing our dietitian, and that could be a split thing. We want the patients to partner with their PCPs, along with the fact that they need to see our own bariatric dietitians. So a lot of times we'll see a hybrid modality where the patient may meet our dietitian 2 or 3 times, but then the bulk of the monthly visits, tracking the patient's progress as far as the diet goes, the burden of that may rest with the PCP if the PCP is so engaged with their own patient. Behavioral modification for people who need it. Sometimes we send our patients to therapy prior to surgery. Depending on their pre-existing comorbidities, they may need other things such as a sleep study to assess for sleep apnea. Some of them may need cardiology evaluation. Although preoperative weight loss is a bonus for the surgeon as far as the surgery itself is concerned, it's not a prerequisite. I know that some insurance carriers will say that you need to lose weight continuously, show us a pattern of continuous weight loss, and only then will we approve the surgery. However, the data overwhelmingly negates that viewpoint. And in fact, the official position of the ASMBS, which is the American Society for Bariatric and Metabolic Surgery, is that preoperative weight loss should not be used as a prerequisite in the planning stage for people to want or to go ahead with bariatric surgery. In fact, most people who come to surgery do so because they are failing traditional weight management options, including diet and exercise. So it's kind of disingenuous to tell them, oh, you got to lose weight before we'll get you to surgery. And in fact, the ASMBS has even represented to all the major insurance carriers to take away that clause, and hopefully we'll see that in the coming year. A lot of them end up, if they still have their gallbladders in, they end up having gallbladder ultrasounds, and the reason is simple. People who still have their gallbladders in and who go through rapid weight loss, as what happens after bariatric surgery, there is about a 47-48% chance of gallbladder problems in the post-operative phase. Now, when you're mobilizing a lot of these fatty acids, when you're reabsorbing the fat from your body, it all tends to precipitate as cholesterol in the gallbladder and then forms cholesterol gallstones. So that's where the problem comes in. And that's why we make sure that these patients are all on ursodiol. We put them on 300 milligrams of ursodiol twice daily for the first 6 months after bariatric surgery, to prevent or to decrease the incidence of gallbladder pathology after bariatric surgery. In fact, with ursodiol, the incidence of gallbladder problems drops to almost 2% from 47-48%, which makes it very acceptable. If somehow they are picking a lab band, then they certainly need an upper GI study, something like that, to assess the anatomy of the upper GI tract to make sure that they don't have any hiatal hernia, significant acid reflux, because a lab band is going to exacerbate all these pre-existing problems. Depending on their history and age, they may need EKG, they'll need a complete set of labs. We'll need a sleep study. Sometimes their Epworth sleep scale, the score will point us towards a polysomnogram. Sometimes it may be just excessive, a history of excessive daytime sleepiness. Sometimes you can look at the neck circumference and use that as a screening criteria to go ahead and order a sleep study. But it's certainly important doing this preoperatively if you suspect sleep apnea, because the last thing you want is for patients to go into a frank respiratory arrest and apnea and frank respiratory arrest and a code blue in the post-op phase. Because even patients with compensated sleep apnea, right now, when you add on opiates in the post-op phase, when you add on the lingering effects of general anesthesia in the post-op phase, in the immediate post-op phase, when you add on the fact that most of the laparoscopic incisions are in the left upper abdomen, and then the patient's probably splinting, not taking deep enough breaths, you have a perfect trifecta where apnea may end up cascading into respiratory arrest. So that's what you want to prevent. That's where the CPAP or BiPAP, AutoPAP comes in. And like I mentioned earlier, cardiac risk stratification is going to also be required for the appropriate patient. Typically, if it's a laparoscopic procedure, 99+% of patients leave the very next day. So if I did their surgeries today, they're likely leaving tomorrow. If it's an open procedure, the average length of stay is, of course, longer. They may end up staying anywhere from 3 to 5 days. And post-operatively, if they are a high-risk patient for DVT or for thromboembolic events, they're going to have Lovenox for a couple of weeks post-operatively. We have calculators on the MBSE website that will allow you to calculate their risk and decide whether they need post-operative DVT prophylaxis or extended DVT prophylaxis. You can actually look at the MBSE, which is the Michigan Bariatric Surgery Collaborative, and the calculator is available for anyone who wants to look at it. I already talked about the ursodiol, and if you're a female, we do encourage some sort of contraception for the first couple of years. Now, there is reasonable data out there that shows that outcomes are poorer if you get pregnant in the first year after bariatric surgery. The morbidity is higher. That's why that's part of it. The other thing is practical. I mean, think about it. In pregnancy, you're having the obstetrician thinking that with each trimester, with each passing month, you're going to gain a certain amount of weight. And, they obviously use that as some of their indicators as to how the pregnancy is progressing. In this case, a patient with bariatric surgery, you're going to have someone who's losing weight throughout the pregnancy. It's going to be confusing. It's certainly not really recommended. And then there are patients who have just done away with contraception because they know in their minds that they'll never get pregnant. Some of these folks have associated PCOS, other problems with infertility. But lo and behold, if you're not going to use some sort of contraception with the weight loss, you're suddenly going to find yourself potentially with unwanted pregnancy if you're not being careful. So that becomes important. Follow-up is critical, very important. We usually see them first week post-op, at 1 month post-op, 3 months post-op, 6 months post-op, and then at the 1 year mark and annually for life. Strict adherence to the post-op protocol is very important, and it's critical for good outcomes. So you can look at it as sort of a timeline algorithm. We initially do the evaluation, preoperative preparation, the actual surgery, post-surgical adjustments may be needed in case of a lab band. Lifestyle changes are going to be important throughout the whole procedure, and that's a lifetime adjustment. It's not just for the period of in the pre-op phase just to get past the insurance requirements. To maintain good outcomes, you're going to have to stick to it for the rest of your life. And plastic surgery may be needed in patients who need abdominoplasty or a paniclectomy or a brachyplasty or a thighplasty. And typically we don't recommend that till at least a year has gone by after the surgery, because by then you're done with bulk of your weight loss, and the weight loss has slowed down by the time you're done with a year. And that may be a good time to assess a plastic surgery intervention. What you don't want to do is get into the plastic surgery option too early. 6 months out, you may have already lost 80 pounds. You go ahead and get abdominoplasty done, and in the next 6 to 8 months, you may lose an additional 40 pounds, and then what do you do? So just wait it out. Typically about 14 months post-op is about a good time to go ahead with the plastic surgery option if that's something you're looking at. We get a bunch of labs and we assess a lot of things, including vitamin deficiencies, micronutrients, macronutrients, minerals, trace elements. We look at a whole bunch of things before we go ahead with the surgery, including Helicobacter pylori status. So who's eligible? What procedure? Those are some of the questions. So the National Institute of Health defines a patient who's eligible for bariatric surgery as someone who's got a body mass index of greater than 40. Just the weight alone will do it, will make you eligible. Or if you have a BMI of at least 35 with some sort of qualifying comorbidity, hypertension, diabetes, sleep apnea, coronary artery disease. There are other comorbidities that will satisfy this criteria. As long as you have at least a body mass index of 35, you're going to be a candidate for bariatric surgery. Now, I'll get to this a little bit later. Most of these comorbidities that you see on the slide will qualify you for bariatric surgery if your body mass index is at least 35. In preparation for surgery, smoking cessation is important. Smoking impairs healing. In fact, if you stop smoking today, the effects of smoking on wound healing, for that reversal to take place, it takes 4 months. So just because you stop smoking today doesn't mean that your wound healing is going to go back to normal 2 weeks down the road. It takes 4 months. It's especially important for someone who's choosing to go ahead with a gastric bypass, because there is a potential issue, a particular complication with the gastric bypass called a marginal ulcer. Now, It's a non-healing ulcer, which a particular risk factor for that forming is smoking. And in smokers, a marginal ulcer may stick around for months without healing. You may put the patient on PPIs twice a day. You may put them on Carafate. You may try this, that. Nothing's going to work unless they stop the smoking. And even after they stop the smoking, it may take 2 or 3 months for the marginal ulcer to heal. All the while, the patient's miserable. They're making you miserable. So just do good preoperative planning in these patients. If need be, they may need testing of the urine and blood for nicotine and nicotine metabolites for you to be absolutely sure. Don't take them on their word if you have doubts. Just objectively ascertain that smoking cessation has actually been done before you get them through to surgery. It's less critical for someone who's picking a sleeve, but just something to keep in mind. Now, alcohol usage, a little wine doesn't hurt anyone. But having said that, there is also data out there saying that, you know, people specifically who have a gastric bypass, you know, this is not true as far as I'm aware for a sleeve gastrectomy or for a duodenal switch, but for people who have, there is an association between a gastric bypass and the risk of alcoholism and even suicidal deaths secondary to that. So just something to keep in mind about alcohol and bariatric surgery. They are all going to be on vitamin supplements for life. And, you know, obviously they have to stop consumption of high sugar liquids, soda, pop. Like I said, preoperative weight loss helps the surgeon, reduces the size of the liver, decreases OR time, the time that you spend in the OR, improves mobility, and decreases the chance that you may have to convert to an open procedure. But other than that, it doesn't change outcome in any way. Follow-up is the primary key to success. And follow-up includes physical exercise, nutrition, behavioral changes, and that's very important. You know, this is not, the patient also is an equal stakeholder in this whole process. You could do the best bariatric surgery on the surface of the planet. You could be in the best institution. But ultimately, if you're not going to be compliant with your eating habits, nothing's going to prevent weight regain. What's to prevent someone from opening up a tub of Haagen-Dazs ice cream? It's high calorie dense food. I could do whatever, restrictive procedure or even a malabsorptive procedure, and it's high calorie food, ice cream just melting in your mouth. It will go right through without any restrictions. And that's not going to work unless there is a fundamental change in your psyche as to you need to make it work. You need to want to make it work. And that's going to be a primary driver of success. So just to highlight the importance of exercise, what fits your busy schedule better? For people who say that I don't have the time to exercise, right? Exercising an hour a day or being dead 24 hours a day. I know that every study that comes out repeatedly harps on the same thing, that regular exercise regimen is beneficial for overall health and is complementary to weight loss. So this is the most important thing that I tell all my patients, that bariatric surgery is a tool for weight loss, and ultimately the successful long-term weight loss is entirely up to the patient as to whether they're willing to make the dietary modifications, activity modifications, and taking responsibility for all regular post-op appointments. The surgery will work regardless in the first year or two, right? You could be the most non-compliant patient I've ever seen on the surface of the planet. I will still get you to lose weight in the first year or two. granted, if you were a compliant patient, maybe you would have lost 125 pounds. But if you are not going to be compliant, maybe you'll lose 80 pounds in the first year or 85 pounds. But you will lose significant weight. The key is the long-term weight loss. And that's where the difference between compliant patients and non-compliant patients starts to get highlighted. You know, what happens when you're 5 years out? And then you'll see the compliant patients still maintain their weight loss, and the non-compliant patients start to put some weight back on. So that's what we have to guard against and be vigilant against. There are multiple procedures. Historically, what you see in the right upper corner is something called the jejunal bypass. It's not done now. It's a procedure that was done in the 60s. It's extinct. And then you see the left upper corner is a vertical banded gastroplasty. It was pretty much in vogue in the early 80s. Again, it's an extinct procedure now. No one does it now. Today, I suspect it would be called medical malpractice if someone did it. The gastric bypass, which is in the center, really had its heyday. It was really in its peak, I should say, in the 90s. It's still maybe considered the gold standard, I would say. The lap band, the gastric banding in the left lower corner, really picked off in the 2000s in the United States. And you know, if you looked at 2007, 2008, around the time, it contributed to 68% of all bariatric surgeries done in the United States. Think about it. If I were in the year 2007 or 2008, I'm essentially telling you that 2 out of 3 patients who had bariatric surgery in the US had a lap band. You know, and that was just mind-blowing. You know, of course, we know better now as to all the downsides, and today the percentage of patients who have lap bands is down to 2% or less amongst all patients having bariatric surgeries. This decade has really belonged to the sleeve. You know, today I suspect 60 to 70% of all bariatric surgeries done in the United States is a sleeve gastrectomy. And of course, the duodenal switch has been increasing slowly in its market share. This is extinct, so I won't even go here. But I'll tell you that I've been doing quite a few revisions. People who have come in with a vertical banded gastroplasty and revision and complications related to that. All of you may have seen some patients in your practices with complications of a vertical banded gastroplasty. And I've actually been reversing a lot of these quite a few of these patients to gastric bypasses, actually. And the complications include band erosion and staple line breakdown, a lot of issues with this procedure. So this is how a Roux-en-Y gastric bypass works. You have a little pouch, a proximal pouch, the capacity of which is maybe about a couple of ounces at most. And then you have a loop of small bowel, which is anastomosed to that small pouch and creating a Roux-en-Y gastric bypass. And you see that pretty much the whole rest of the stomach, the whole duodenum and the proximal jejunum is all bypassed, meaning food is never going to get there. And that's where some of the problems, the malabsorptive problems with the gastric bypass comes in. So for example, the duodenum, the proximal small bowel is where about 65 to 70% of the iron absorption takes place. So you may have a patient who is taking a normal amount of iron with their diet after a gastric bypass, and then you may see them develop iron deficiency anemia. And this is why, because they are bypassing the portion of the gut where most of the iron absorption takes place. So you have to be cognizant about the anatomy and how it segues into what you are going to see with the patient post-operatively. Okay, so you'll see about a 60 to 65% excess weight loss at around the 5-year mark with Roux-en-Y gastric bypass. Like I said, it's both a restrictive and a malabsorptive procedure. And the commonest complications that you're going to see with bypass, and this is going to be a common theme with any bariatric surgery, so I'll keep it common to all the procedures. By far, the commonest problem that we see is nausea after the procedure, or people will say that I'm throwing up. They may not really be quote unquote throwing up or emesis, rather they may have some regurgitation or reflux, dehydration, very common because they're not taking in enough fluids, they're not keeping themselves adequately hydrated. The rest is very infrequent. You know, you can always have bleeding complications from any surgery, wound infection, certainly possible. Don't see it very often. The biggest two issues that I usually worry about that are potentially life-threatening, and that's why I worry about them. It's a DVT, which can then form a, go on to be a P. Obviously, that can potentially be life-threatening. So that's why early ambulation is encouraged. In fact, all our patients, we get them up and moving on the day of surgery. On the same day of surgery, post-operatively, the nurses encourage them to walk around. They are immediately started on Lovenox the same day after surgery, things that we can do within our control to prevent a DVT formation. A leak. A leak is a low probability. If you look at the data from the American College of Surgeons, the likelihood of a leak today with bariatric surgery is about less than 1%. So it's a small likelihood, but it is a possibility and a potential very, it could be a fatal outcome. And that's why it's important. A leak by itself is not going to be fatal. Only an undiagnosed leak is going to be a problem. If you understand the leak, if you pick up the leak immediately, then potentially you could deal with it very effectively early on. It may certainly lead to an increased length of stay. You know, your patient's certainly not going home on post-op day 1 if you have a leak. But then you can very well deal with it very successfully as long as it's picked up early. So early diagnosis becomes the critical intervention there. You have bunch of late issues that can happen as with any surgery. You know, you have various nutritional deficiencies, particularly a little bit more common with the gastric bypass and with the duodenal switch as compared to a sleeve gastrectomy or with a band. Certainly, as with any surgery, you can always have the possibility of bowel obstruction. I talked about the marginal ulcers earlier. You know, among smoking, you also want to avoid NSAIDs, aspirin, things like that, which can be a risk factor for these sort of things happening. With the gastric bypass and with the sleeve, you can certainly even have a stricture that can form. And that's something, you know, a lot of times if it's a stricture with the gastric bypass, you may need a endoscopic dilatation, and hopefully that's the end of that. A lap band, again, like I said, it's not really the procedure of choice today. I usually try to dissuade my patients from going ahead with it today because there are better procedures out there. But in spite of my best intentions, my best efforts, if the patient still says, "Doc, I understand all what you're telling me, but this is what I want," I'll still do it, you know, because ultimately it's the patient's informed choice. The reason I don't advise this as a first choice today is multifold. It's the procedure associated with the slowest weight loss. It's very slow. It's associated with the least amount of weight loss. So if you look at the excess weight loss associated with a lap band versus a sleeve versus a bypass versus a duodenal switch, the lap band is the lowest number in terms of excess weight loss. If you look at, diabetes, right? Let's talk about diabetes and bariatric surgery. So when we talk about the remission of diabetes with bariatric surgery, it's not a straight number associated with all procedures. It's different for each procedure. So if you look at the remission rate of diabetes with the lap band, it's about 40%. If you look at the remission rate of diabetes with the sleeve gastrectomy, it's 70%. Remission rate of diabetes with the Roux-en-Y gastric bypass, about 83%. Remission rate of diabetes with a duodenal switch is about 98%, 99%. So you can see that it doesn't match up to the other procedures. It's not even in the same ballpark. Even other things, you know, all the other procedures, once you're done with it, you're done. This is a procedure where the patient may need to come in lifelong potentially for adjustments in the post-operative phase. And, you know, eventually once the patient's outside of the 3-month post-op phase, that may attract some co-pays for the office visits, which the patient may not like. It is the procedure that's associated with the highest reoperative risk amongst all bariatric surgeries. So the data is not very favorable to the lap band. So there are 2 different bands. One is a lap band and one is a realized band. It doesn't matter. They're both the same for all practical intents and purposes. There are some complications, particularly unique to the lap band, including tube fractures and erosions of the lap band. But, you know, upper GI studies and endoscopies can usually pick up these sort of complications. You can see a flipped port on X-ray or fluoroscopy, which means you are going to have difficulty in associating the lap band to adjust the volume of fluid in the balloon. And sometimes you may need to revise the subcutaneous coat. This is a erosion. You can see contrast, the thin rim of barium flowing both through the band and around the band. So that indicates that the band has eroded into the gastric lumen. Obviously, in this case, the band has to come out. And you can see an endoscopic picture. That white reflection that you see is the lap band eroding into the gastric lumen. And the pink that you see is gastric mucosa. And this is how a lap band looks on fluoroscopy after adjustment. You'll see a small proximal gastric pouch, some contrast flowing through, and then what you see distally is the large air gas bubble in the fundus and contrast going through. This is how a herniated lap band looks, a gastric prolapse. You'll see that there's a whole volume of stomach, a large volume of stomach that's herniated above the lap band. And obviously, this is not going to cause any amount of restriction, and this is going to cause a lot of problems. And this is a duodenal switch. Essentially, I'll simplify it as a combination of a sleeve gastrectomy and a gastric bypass. But this is a very potent bariatric surgical procedure. You have a very small number of surgeons doing it. In Michigan, I know that being part of the Michigan Bariatric Surgery Collaborative, we know the data for the whole state because every participating institution gets access to the pool data. And I see that, you know, in the mid-Michigan region, I think we are the only program who does the duodenal switch. There is a program down in the Detroit area that does it. There is a program in the Grand Rapids area that does it. There is someone up north, but it's a handful of programs in Michigan, maybe 4 or 5 places that do the duodenal switch. A lot of surgeons aren't trained in this procedure, so that's part of the reason. But if it's just a matter of potency, just of the procedure, nothing to beat the duodenal switch. The sleeve gastrectomy is a procedure in which about 80–85% of the volume of the stomach is taken out, leaving behind about 5 ounces, really. That's all that's left behind. The volume of the sleeve that you see left behind is just that. And then that leads to weight loss. That's the restrictive portion of it. But you also have to understand that there are also hormonal mechanisms in play. with the resected volume of the stomach, the fundus is gone, which means most of your body's capacity to produce ghrelin is gone along with that. Ghrelin is the putative hormone that drives appetite. So you also have a sense of satiety once you have the sleeve, and that also helps with the weight loss. Every procedure comes, so for example, after a Roux-en-Y gastric bypass, you see the levels of GLP-1 skyrocket. They really skyrocket 12 hours after gastric bypass. If you did an assay to measure the GLP-1 levels in your body, they're off the charts. So the effects are very quick, and that's why patients who have bariatric surgeries, have a gastric bypass, we encourage them to closely follow up with their primary care providers so that they can adjust their insulin dosage. They can adjust the dosage of their oral hypoglycemics on a constant basis based on what their blood sugar levels are doing. And that's important, especially in this patient population. There are other options, including gastric pacing systems for weight loss. There are endoscopic options for weight loss. All of these are still considered to be experimental. So I'm not going into it in detail because they're not covered by the insurance carriers. Just a word about intragastric balloons. There are two balloons. One is called the Orbera, one is called the Reshape. Both of them are FDA approved. Basically, we drop the balloon endoscopically into the stomach, and then we blow it up. So it takes up space, and then the patient can eat as much as they can do. This is the FDA has approved it for the balloons to stay in place for up to 6 months, and then it needs to come out. So the main understanding is that this is a reversible procedure, and that's how it's got to be. And this is a different category of patient. This is not a good procedure for the morbidly obese patient, with a body mass index of 50. This is really for the patient who's overweight or obese, maybe a body mass index of 34. This is for the patient who says that I've done my best. I've really stuck to my diet. I'm really exercising a couple of hours, an hour every day. I've tried some medications for weight loss. I just can't seem to, find a breakthrough. I can't seem to get past this weight loss plateau. This is for that patient. If you look at the average excess weight loss for a gastric balloon, it's about 35 to 40 pounds. So it's a modest weight loss, and expectations have to be set appropriately. Now, you'll always have the superstar patients. Once in a blue moon, I have patients who have gone on to lose 80 pounds with the gastric balloon, intragastric balloon. But that's the exception rather than the rule. I always tell my patients, expect about 40 pounds, and that's what you're going to see with the intragastric balloon. So I think I went into some of these things. You're going to restrict the amount of calories. There are hormonal changes that take place with the local GI tract. There is going to be altered gut motility. So there is accelerated, gut transit time. So after a sleeve gastrectomy, you'll see that things really whiz past the GI tract to the distal bowel, thus allowing less time for the bowel to absorb the nutrients. The same thing with the bypass. We are delivering nutrients. We are bypassing the proximal bowel, and we are delivering it to the distal bowel, so there's lesser time for these nutrients to get absorbed. Granted, it can cause problems with loose stools because of that, but usually the small bowel habituates itself to the changed status quo over a period of time. Now, the quick delivery of nutrients to the distal small bowel also means that there are other neurohormonal changes that take place in these patients with bariatric surgery. So for example, peptide YY, you're going to see an upshoot in the peptide YY levels in these patients because of the accelerated delivery of nutrients to the terminal small bowel. So you have studies in which two groups of patients were completely blinded, and they were told that you could eat, you put into a all-you-can-eat buffet, no holds barred. You can eat whatever you want. One group had placebo injected. One group was given peptide YY. Now, the average calorie consumption of the patients who had the peptide YY was 30% lower than the group that got placebo. 30% less calorie consumption in all-you-can-eat buffet. Now, the groups were reversed. The people who previously got placebo are now given the peptide YY and vice versa, and the results completely flipped. The patients who got peptide YY with the reverse group, now they consumed 30% less calories compared to the other control group. The reason I'm bringing all this forward is that bariatric surgery is not just a restrictive procedure. All these anatomical changes that we make means that they're also changing the local GI gut hormone milieu to bring about changes that way. So what do you define as success? Is it just the weight? Sometimes it's resolution of comorbidities. Sometimes it's a particular expectation that the patient has. So you need to be very careful in having a good discussion preoperatively with the patient. What is it that they want out of the procedure that will define success for them? So it's a very significant public health problem, and it's got both healthcare and health implications and economic implications. The United States is a global leader in everything. As you can see, the left upper corner of the slide, we are the leaders in this too. No surprise there. No wonder why. This doesn't help either. And if you look at the BRFS data, they first started gathering this data in '85, and look at a time-lapse sequence of the prevalence or the incidence of obesity in different states across a period of time. This is in '88. More states are getting into the obese category. This is in '90. This is in '94. And this is in '97. We now have 20%, more than 20% of some of the southern states. And look, that's in 2000. And now we have, 2001. And look at that. A quarter of the, greater than 20%, that's 2004. Now we have a new category, greater than 30% in 2007. And this is the current data. You can see that it's truly become a nationwide phenomenon, and that's just unfortunate. And it starts with childhood. We have multiple papers saying that there is a direct correlation between childhood obesity. These are the individuals who go on to become obese and morbidly obese as adults when you're overweight as a child. And this is a slide that it looks a little busy, but it tells you various comorbidities that can be resolved, or you have some sort of remission after successful bariatric surgery. So if you look at PCOS, you'll see about 80% resolution of hirsutism, 100% resolution of menstrual dysfunction. If you pick something like asthma, there's 82% improvement in that particular comorbidity or resolution. So if you look at the left side, you'll see that 83% resolution of diabetes. It also reflects in the lifespan. So if you are a morbidly obese, black gentleman, you'll see that your expected lifespan after successful bariatric surgery is going to be about 14 years longer, um, because of the gain of the uh, lifespan after bariatric surgery. And there are multiple papers that you've seen in your own medical journals like JAMA. It's all over the place. Morbid obesity is truly the grim reaper. So, these are the traditional methodologies for weight loss: diet, exercise, pharmacology. If you look at lifestyle, the hard way, sometimes that's just not enough for most people. And that's where the National Institute of Health consensus came in, that people could go ahead and have bariatric surgery. Even with some of these, syndicated weight loss dietary interventions, you can see that the weight loss is not very significant long term. You'll always see patients sometimes say that, oh, I lost 50 pounds with this diet at the 6-month mark. But you look at the same patient a year out, they've in all likelihood gained a lot of that weight back, and in some cases, a little bit more than where they started out. So that's the problem. Long-term weight loss, not just short-term weight loss. The FDA certainly has approved a whole bunch of medications for medical weight loss, and you just need to demonstrate a 5% weight loss for something to qualify as a weight loss drug. So the bar is certainly set very low. This is in contrast to bariatric surgery, where we are talking about excess weight loss of 65%, something in that range. So why it works, and this is the National Institute of Health algorithm that they put up on their own website. So if you're overweight, yes, by all means, diet, physical activity, exercise, this is all going to help. If you're a little bit more, a few more pounds to shed, then maybe you can add pharmacological interventions to your algorithm. But once you get into the body mass index of 35 and above, bariatric surgery is what's going to be most effective. So there are a lot of studies. The Framingham study showed 82% improvement in the relative risk reduction of cardiac events after bariatric surgery. You have a JAMA article published in the Annals of Journal Surgery showing a 89% reduction in mortality after bariatric surgery. You see there was a publication in the New England Journal of Medicine by Adams showing resolution or remission of diabetes of 92%. So if you say, yeah, it works, but it's expensive. So if you look at the medical economics aspect of it, in 2.5 years' time, the costs associated with bariatric surgery are usually recouped. And then anything else after that is just a bonus and savings for the patient. So if you say, okay, it works, and it can be cost effective, but is it dangerous? Now, the comparative mortality is less than the mortality of what you see with something like a hip replacement. In fact, the current numbers, the current data, and you can look at it on the American College of Surgeons' own website, is less than or is comparable to that of a cholecystectomy right now, the mortality from bariatric surgery. So, you may have had opinions about bariatric surgery from the 90s. That was a different era. People had a different way of doing things. There was a lot more open surgery 20 years ago than it is today. Today, the data is radically different. So shouldn't it be the last option? So I'll tell you, it's the same thing that we talked about earlier. It's like a pyramidal system. If your body mass index is at the bottom of the pyramid, then you can go in for less invasive measures. But as you start moving up the pyramid, then your surgery becomes the option to go to, especially when you're in the top off of the pyramid. So laparoscopic surgery, a lot of you may have had patients, it's very, the incisions are a 4 or 5 incisions that you barely see. Open surgery certainly may leave more of a mark. If you think about bariatric surgery and diabetes, there are multitude of studies demonstrating benefit in diabetes. The one thing to notice is the longer someone has been diabetic, the less likely the chance of bariatric surgery working is. You have to make sure that the patient's pancreas hasn't been burnt out, for lack of a better term. That's how I'll put it. But as long as you're not in that scenario or situation, bariatric surgery certainly has a very good chance of helping with the diabetes or even decreasing the patient's requirement of insulin very significantly, or decreasing the dosage or the number of oral oral hypoglycemic medications that your patient is going to be taking. So these are the respective state obesity rates as of 2019. You can see that Michigan is 36%. Of course, the southern states, Mississippi is the leader with 40.8, and Colorado seems to be the healthiest state. This is one of my patients, reproduced with permission from the patient. There is no HIPAA violation here. She's actually a nurse who went on to do very well after surgery, and who resolved or put her diabetes into remission and has continued to be a non-diabetic. It's been 15 years now. She's done exceedingly well. So I may have given you all these facts as to why patients should or can have bariatric surgery, but when you poll the patients themselves, they gave improving appearance as the #1 reason that the patients gave for going through with weight loss surgery or bariatric surgery, and the #2 reason was feeling better about themselves. The concerns about health was just #4, when you had a truly anonymous, unblinded feedback from the patient. So I think the most important thing is not being judgmental about the patient. Some of us are Chihuahuas. Some of your patients are St. Bernards. There is no quote unquote right body size or right weight for everyone. Everyone's distinct. So I think, just appreciating that difference becomes very important in the pre-op phase and in the post-op phase when having discussion of bariatric surgery with the patients. Now, both Ascension Genesis and Ascension St. Mary's hospitals are doing the bariatric surgeries. A lot of you have already been referring patients to both these centers. Both Ascension St. Mary's and Ascension Genesis Hospital, it's a tier 1. We are tier 1 providers for your patients, especially within the Genesis PHO, which means that they are not going to pay, or they have the least amount of copay or whatever that they need to pay out of pocket. And some of your patients may need to go to a accredited center of excellence. Now, Genesis is still not a accredited center, but we are certainly on our way to getting to that point. We are still building up our case volumes at Ascension Genesis Hospital. Ascension St. Mary's Hospital is a fully accredited comprehensive center. It's also a Blue Distinction Plus Center of Excellence. So pretty much any patient, all insurance carriers, including carriers we consider typically crappy like United Health, they can all be done at Ascension St. Mary's Hospital. Any questions?
All right, we have one question in our chat box.
Okay.
please, if you can, please put your questions in the Q&A. The question from our chat box states, I'm sorry, it just disappeared on me. Is there any effect by chronic marijuana use?
So there is the objective, and we always advise the patient not to use marijuana because we think that it may have altered some effects on both their appetite and on gut motility. However, objectively, the evidence states that it does not affect outcomes. I personally tell them, hey, stay away from it if you can, but that's just my practice pattern. The evidence does not suggest that there is any change in outcomes after bariatric surgery in marijuana users.
Okay. Next question, what supplements are lifelong?
So they're going to be, a lot of it depends on the procedure. So if you take someone with a biliary pancreatic diversion and duodenal switch, it's more of a malabsorptive procedure. So all these folks, they are going to be on bariatric multivitamins. They're going to have iron supplementation, like Flintstones, something like that. They're going to have malabsorption with fat-soluble vitamins too. So they're also going to need vitamin A, vitamin D supplementation. So if you take someone like a sleeve gastrectomy, typically we check for these deficiencies annually, but they do not necessarily need to be on vitamin A supplementation because it's a very low likelihood that they will develop this sort of a deficiency after a sleeve gastrectomy. But they may need some vitamin B12 supplementation. Especially you take someone with a gastric bypass, like I always previously mentioned, these folks may be deficient in iron absorption, and the B12, sometimes we just do something called Nascobal. It's a nasally absorbed once weekly spray of vitamin B12 that we do, which bypasses the first pass metabolism of the liver. But essentially, the message that we send out to a lot of these patients who are considering bariatric surgery is some of these supplementations are going to be lifelong, because any patient with bariatric surgery with significant weight loss is always going to put themselves at risk for nutritional deficiencies. And we want to hammer that point home that some of these multivitamins, these mineral supplements may be lifelong.
Okay. Our next question is, how old is too old for bariatric surgery?
My oldest patient that we have done, and we've done quite a few of these in our program, my oldest is actually 83, believe it or not. 83 years old, God bless us all, had bariatric surgery. The data, so there is no limitation, nor will your insurance carrier stop you. It's a patient preference. So there is no limitation saying that, oh, you're 72 years old, so you cannot have bariatric surgery. There's nothing like that. Having said that, you just have to understand that your recovery, the older you get, your recovery, even with laparoscopic surgery, is going to be a little bit on the slower side. And post-operative exercise, activity levels are an inherent part of how much weight you're going to lose. And with increasing age, your ability to engage in physical activity, exercise, naturally comes down. So that's a limitation that you have to factor in. So people who otherwise may lose 120 pounds may, because of the fact that they are 78 years old, may lose 90 pounds because they are not putting the physical activity into it, and it's just a procedure working independently all on its own.
Okay, our next question is do you check insulin levels before surgery?
I don't. We leave that part up to the endocrinologist and to the internists, if they're going to check for those levels and even look at C-peptide levels and stuff like that. We leave it up to them to titrate their insulin requirements and all that stuff. But that's for the internists. I don't get into it myself.
Okay. Has there been changes in the psychiatric evaluation pre-surgery? I have had patients go to surgery and not be successful because of lack of behavioral changes.
So I think it's important to pick a good psychologist or a psychiatrist. I have seen psychologists or psychiatrists pretty much rubber stamp anyone we send to them. And I don't know, maybe it's a feeling that, that I won't send them my patients if they reject the patient for surgery, or they give me feedback that the patient is not ready for surgery. I, in fact, welcome that sort of a feedback, because it prevents the patient from going ahead with something that's not going to be effective for them. We have had multiple such rejections, and I really love those mental health providers who actually have stopped patients from going ahead with surgery because they've seen a red herring. In those cases, a lot of times we have been able to successfully put them through therapy, cognitive behavioral therapy, get them to a therapist. It may have taken 6 months, but we have been able to demonstrate inherent fundamental changes in their way of thought process, and then send them back to the same psychologist, who then does a reassessment and now says that, yep, now we see we can validate that this patient is ready for surgery. So that's what needs to happen. So I truly don't want a rubber stamp psychiatric approval for surgery.
Next question is a follow-up. How old can the youngest patient be? To do pediatric patient with BMI of more than 35, type 2 diabetes, can they have bariatric surgery?
So once you are at least 16 years of age, and they have a good head on their shoulders, they can be considered to be emancipated adults. And 16 plus, meeting the above set criteria, can have surgery done.
What is the average A1C reduction post-surgery?
Depends on the compliance of the patient. So that's going to be very important. And the choice of surgery. So you may have someone starting out with a hemoglobin A1C of 13 who has a duodenal switch, and they may end up with a hemoglobin A1C of 5.8 a year out. The same patient may have a gastric bypass and may end up with a hemoglobin A1C of 6.3 a year out. The same patient may have a sleeve gastrectomy and may end up with a hemoglobin A1C of 6.6 a year out. The same patient may have a lap band and may have a hemoglobin A1C of 7.1 a year out. Compliance, again, if it's a very good compliant patient, you're certainly going to see better outcomes in hemoglobin A1C reduction.
How do you treat the worsening GERD or vomiting bile after surgery?
So GERD is certainly a very important problem after bariatric surgery. We have a host of options. Obviously, we start with PPIs and with lifestyle changes, behavioral modifications. Sometimes you can, try things like metoclopramide, prokinetic agents. If nothing works, you have endoscopic options. There is something called STREDA, where you do a radiofrequency ablation of the GE junction that remodels the lower esophageal sphincter to prevent acid reflux. So that's the endoscopic option, just the EGD, and it works well. It all depends on what procedure, obviously, that the patient had to begin with. But if there is a little bit of if there is fundus left behind, then you could do something called the endoscopic TIF procedure. There is something called a Lynx procedure. It's a magnetic sphincter. It's like it's a magnetic augmentation of the lower esophageal sphincter that we can do. That's called the Lynx procedure. worst case scenario, all fails. We've gone through all these options, nothing works. Then, so for example, let's say a patient had a sleeve gastrectomy, intractable GERD, nothing worked. We may unfortunately need to convert the sleeve to a Roux-en-Y gastric bypass to prevent this bile reflux gastritis.
Okay, we have just three questions left, and hopefully we can get through them quick. What is the criteria to get a tummy tuck after bariatric surgery for insurance to cover it?
So there are, if you really have a good plan, it may cover the tummy tuck or abdominoplasty no matter what. But most insurance carriers will put impediments in your way, and they'll make your patient jump through loopholes. The easiest, and they'll ask your patient to meet the medical criteria, like you mentioned, to qualify for abdominoplasty. The easiest way to get the patient to qualify for that is documentation of recurrent skin rashes associated with the abdominal skin fold or the abdominal pannus. Because of the weight loss, they have these rashes in the abdominal skin fold. If you can document that, 2 or 3 times and say that, this is what we tried. We tried some astringent like zinc oxide cream, or we tried antifungal ointment, or we tried antibacterial ointment, and it didn't work. If you have that documentation 2 or 3 times and it's an ongoing problem, this will satisfy the criteria for the insurance carrier to say that you now met the medical criteria requirement to go ahead with bariatric surgery, with abdominoplasty after bariatric surgery. So that's what I would state. Document this, and then your patient will be able to have the plastic surgery.
Do you hold informational meetings for people who are considering surgery?
Absolutely. Just because in this era of COVID-19, it's all online. I think we do it twice a month. It's all online informational webinar, just like what we are doing now. And if the patients don't want to consider bariatric surgery, if they don't think that it's something for them, they don't have to do anything. Conversely, they can get through this process. Remember, depending on what insurance they have, they may have a mandatory 6-month period of medically supervised weight loss anyways, even before their insurance carrier will approve surgery. So they may start the process of medically supervised weight loss with you, the PCP, and then when it's 6 months, they can then decide whether they have accomplished their weight loss goals, or if they are still considering bariatric surgery at that point. So they're not losing anything by starting this process. Till they sign that consent, they're not committing themselves to surgery in any way or fashion.
Okay, we got a little less than 2 minutes left before we have to start the other one. Why are the patients not followed by the bariatric center for at least 5 years?
They should be. In fact, it is our own protocol is, like I mentioned, we have mandatory follow-ups at the 1 week post-op, 1 month, 3 months, 6 months, 1 year, and then annually thereafter. And if they don't return our call for follow-up appointments, we actually document at least 2 more follow-up calls to the patient, asking them to make an appointment for follow-up. We want to see you. And if we get no response to that, we then send them return communication to their last known address saying, you need to come and see us. And this is protocol. There is no exception to this rule. We do this for all our patients. And only if we don't get a response to all this, then it's the patient's own non-compliance. But this is all what we do. There are no exceptions to this rule, no excuses on our side as a program for all patients who are part of our program. Having said this, I do see so many patients my own patients who have come to me from other programs in the community, from other programs in the Flint region, from other programs in the Saginaw region, who explicitly tell me that they felt like in their programs, they had bariatric surgery and then they were just abandoned, left free to fly in the wind. No one ever saw them after. So I know the sentiment. I know that's how other programs have potentially dealt with patients in the past, but that's not who we are.
Okay. For those of you that are waiting for the code, today's EADS code for this first lecture is 85. C as in cat, U as in umbrella, D as in David, S as in Sam. Dr. Stalin, we did not get to all of the questions today. I ask everyone, if you would like your questions answered, please email them to Dana, D-A-N-A, .Bertram, B-U-R-T-R-U-M, @ascension.org, and we will forward them to Dr. Stalin for follow-up, and then he will contact you directly. Again, I look forward to seeing everyone at our next lecture. The code for this lecture is 85, C as in cat, U as in umbrella, D as in David, S as in Sam. Thank you, Dr. Stalin.
Thank you so much for having me on.
Have a good day.
Bye now.